everybody did enjoy dinner, and as you get settled, I'll say who I am, because that's the least influential part of this panel. My name is Virginia Brennan, and I work at Harry Medical College, which is about a mile from here. And I edit the Journal of Healthcare for the Portland Research, which was started almost 25 years ago by Dr. David Stategy. And a true visionary who, is a lot of things that he thought about 25 years ago have come to pass. So there's some inspiration. And tonight we're going to hear from four of what, in my mind, are the most prominent people in the healthcare justice movement in the state of Tennessee, which is vibrant in a context where a lot of people might give up. So they have not. And so we'll be hearing from four people: Dr. Art Sutherland, from Attorney Gordon Bonnyman, from Mary Bowfleck, Dr. Mary Bowfleck, who's the CEO of United Health Centers, and from Tony Garr, who led the Tennessee Healthcare Campaign for 21 years and just never stopped fighting a good fight. I may say more about each one as they come up, but Dr. Sutherland, I think is the coordinator of the Physicians for National Health, for a national health program here in Tennessee, and is on their national board of directors, in addition to being a now retired cardiologist.
Well, is this on?
No.
Mm-hmm. I'll just start out telling you a little bit about myself, because as I explained how I got into healthcare justice. Basically, I started cardiology practice in 1971 in Memphis, and developed a cardiac lab over at Methodist Hospital, and built a group up to about 18 cardiologists before I retired. And along the way, I pretty well burned out to medicine with the complexity of running the practice and dealing with the multiple insurers and all the trauma that goes through. And unfortunately, I lost my wife during that period of time. We were married 40 years, and she died of breast cancer, so I had to see the healthcare system through the eyes of a family member and a caregiver. And so after her death, I had to do a lot of discernment and to really see what I was going to do. I wasn't ready to retire for another 2 years, and during that 2-year period, I got involved with a group in Memphis, and was actually one of the founders. The group was called the Healthy Memphis Common Table. And we got together to work on the problem of obesity and diabetes, which was rampant by that time. And our mission was the unfunded mandate to try to reverse the obesity epidemics in Memphis and West Tennessee. So we worked very diligently on that for 5 years. Followed by commercial appeal and also channel 3 television, both strip salaries, podcast, and movies. And when we published our 5-year result, we showed that we didn't do much. The obesity and diabetic epidemics kept going up. But what we found out was very valuable lessons. We approached this like a medical problem. We find a problem, we educate people about what to eat, I'd exercise more, and everything's going to be okay. Well, that's when I first learned about social determinants. And social determinants trump good intentions. It's probably the biggest lesson in my life, and it's driven me into the whole area of population health. So I look at inequality of access to care as a first step in the whole process of not only improving individual care to make it accessible for everybody, but also as the first step in really unifying the country to work on the social determinants of health, which fall outside the medical health system, and to really work on improving population health of our country. Because we believe that healthcare is a human right, and we feel like that we can do everything AAA wants. We can cover everybody, we can reduce costs, we can improve the patient experience to improve the quality of healthcare delivery. We just have to have the right system, and we need to quit thinking in the box that everything has to be done, has to be insurance companies. Think outside the box and figure out the right way to do it. Thank you.
Try this mic. My name is Gordon Bonnyman. I'm an attorney with Tennessee Justice Center. It's a small public interest law firm here in Nashville. Before that, I was a legal services lawyer. I've been practicing for 40 years, and much of that has been around health access. And most recently, I've been involved in the effort to convince the state to expand its Medicaid program, which is known as TennCare. We have a history here, and several good friends in the room are part of that history. You're going to hear from Tony Garr in a second. 20 years ago, Tennessee, improbably enough, as a southern state, it usually invokes its state motto of "Thank God for Mississippi," because actually, you can look on the state seal; it's in Latin, and none of us speak Latin. I'm told that's what it says. I don't know. But you know, we're used to being 49 if we're not 50, if we're not 51st, in most things. And then 20 years ago, we suddenly jumped ahead and had, for a while, the lowest number of uninsured people as a percentage of our population in the country. It was a remarkable story. It taught me a number of things. We had a confluence of events. We had a governor who was born in a sharecropper shack in the middle of a cotton field in West Tennessee, was an old Southern Democratic populist who had really grown in office. When he came to the legislature, he had sponsored mandatory sterilization of welfare mothers, and he came a long way, and he always cared about health care, and so he had a very shrewd finance commissioner who I think a lot of innovation we know comes from people who are on the margins of a profession or of a science. And David Manning was a finance whiz who came at healthcare from the standpoint of financial management, which I know probably makes a lot of people's flesh crawl, but it's absolutely critical. We also had a Medicaid director, Manny Martins, who was the son of an illegal immigrant. He was a longtime public health officer, deeply dedicated to improving the health of populations. And he also knew how to run Medicaid. He knew what a sort of jury-rigged thing it was, how awkward it is, and he knew how to make it work for people. And so the three of those people came together, and the governor provided the muscle, and David Manning and Manny Martins provided the insights to starting something that they called TennCare, which was expansion. It was the first really major Medicaid waiver after Arizona, and it expanded Medicaid to working people who were childless. All you had to do was say that you did not have access to coverage, and you could get care on a sliding scale no matter what your category, no matter what your circumstances were. Sounds kind of familiar, doesn't it? That's, of course, what the Medicaid reform is supposed to be under the ACA, complemented then for people above 138% of poverty with the access to premium tax credits and private insurance on the exchange. What happened was that we greatly expanded coverage. As I said, we reduced uninsurance dramatically. It's always struck me as peculiar that we talk about having a mandate, an individual mandate. In my experience, people who are uninsured, except for maybe motorcycle riding young Republicans who drunk the Kool-Aid, are desperate to have insurance. Desperate to have insurance. and they understand fully. And so it's always struck me as kind of crazy making that we think that these people are so irresponsible that we have to order them to get it. Just make it possible, and they will come. That's what the TennCare story taught. It was dramatic how quickly people came to sign up, and this was in the midst of computer screw-ups, horrible press, doctors screaming bloody murder, insurance companies whining that they weren't getting paid enough. Again, it's deja vu all over again now. And we soldiered on, and it succeeded. What was interesting, though, was that it was never popular. If you look at most of the studies, it was never really accepted, I think, as legitimate health reform by the sort of policy wonks in the Northeast and in Washington. I think part of that was because it was Tennessee. Thank God for Mississippi. It was also based on leveraging a lot of federal dollars in some fairly creative ways. But mostly it was because I think it wasn't an idea that the elites had come up with. It was its beneficiaries were low-income and blue-collar folks. And one thing I learned from the experience was that if a program, if that's its constituency, it's going to need a lot of help from those of us who are more privileged. What happened ultimately was that the subsequent governor was well-intended but not very able, and served by not very able staff. The budget began to get out of control. If you look now at TennCare, you Google it, you'll find the common wisdom was it was too ambitious to try to cover people. You can't afford to cover people. It was breaking the bank. That was BS. What was really going on was that there was a big income transfer, wealth transfer from the healthcare establishment and insurance companies to low-income and disadvantaged people. And ultimately, the wheels came off of that politically. It was a policy success. It was a public health success. And I say that with a keen awareness that getting people insurance is not the same thing as ensuring that they have adequate care. But it is a necessary first step. And it did begin to have an impact even on health status. So it's far from perfect, but it ultimately worked after some rough start. And it worked for a while until it couldn't withstand the attacks politically anymore. It didn't fail because it was not successful, good policy. It did not fail because it was not saving lives and relieving human misery. It failed for a lot of political reasons. And so in that, I think, is a lesson about the experience that we're collectively going through right now. The ACA, as we all know, is deeply imperfect. In my office, we're all about getting access. We're all about publicly putting a smiley face on the ACA. The other day, someone said, shit, forget about repeal and replace. Let's just repeal the damn thing. It's complicated. It's messy. It's what we got. It's got to work. And it will only work if those of us who are privileged and who know what the truth is are messengers to the rest of the country on behalf of the mostly disfranchised people who stand to benefit. I think it is an enormous challenge. It's an enormous opportunity. And I can tell you from the experience that we had 20 years ago, it's one that we can't lose this time.
We can't.
Thank you, Gordon. I'm Tony Barr. I'm currently working with Enroll America. We're trying to maximize enrollment under the Affordable Care Act. I did work with the Tennessee Healthcare Campaign for 21 years as its executive director, as its first director. And Gordon was the one that called me up one day and says, the governor wants to talk to us about the TennCare, and so this was back in 1993. But let me sort of share with you another perspective about TennCare and the importance of what's happening right now. So in April of 1993, the governor of Tennessee asked the Tennessee Healthcare Campaign to help move this program forward. There was no support in the legislature. The doctors were opposed to it. The hospitals were opposed to it. So how was the governor going to do this? And so he called upon consumer advocates to make it happen. It became known as TennCare and was one of the first comprehensive 1115 waivers. Basically, it was the state asking permission from the federal government to use federal dollars to expand coverage, but not to spend any more than it would ordinarily. From the beginning, I was concerned about the waiver because it was a state waiver. It was not protected, the waiver was not protected by any federal law. In other words, the governor goes out, get a new governor in, is this new governor going to protect this? I don't know. But there was a consolation as we were going through this. I remember David Manning, who was commissioner of F&A, said, and even the governor said too, we got a constituency. You know, after about 300,000 people, Tennesseans were enrolled, he says, we got a constituency. And I took some consolation in the fact that maybe it will hold together. But we've all seen programs in Oregon, programs in Maine, in programs in other states or other initiatives where there was expansion, and after a while they failed for one reason or the other. But under the ACA, we finally have some protections, not just for coverage of the 45 million Americans who are uninsured, but we also have protections for the 160 million Americans who do have insurance through your employer. The benefits and the protections are genuine. So as we move around from job to job or from sickness to health and health to sickness, we have protections we never had before, and they're guaranteed by federal law and not state law. So when our governor basically, when he started the program, and this was a Democratic governor, and we actually went through 8 years of a Republican governor who tried to sort of get rid of it, but thanks to Gordon and others, it never happened. But we ended up losing it by a Democratic governor. The Democratic governor was the one that actually sold the Tennesseans on the fact that, you know, this is a failed program, it's cost me too much, I can't afford it. The reality is, like Gordon says, it was really a political problem, it was not a financial problem. And the governor says, I'll make sure that no one gets hurt. Well, he was wrong. There were people who died because they lost coverage, but that's what we had to deal with. I'm concerned about a similar political dynamic that's happening right now. The opposition to the ACA is not just coming from the conservative right, but it's also coming from the progressive left. On the NPR this morning, I don't know how many heard the NPR story this morning about a thoughtful analysis about what was happening over the last 20 years concerning congressional districts. Because of the redistricting over the last 20 years, basically what used to be, there used to be a bunch of swing congressional districts. Those swing congressional districts are now really no longer swing districts because of the redistricting, and they're pretty much locked either hardcore Republican or hardcore Democrat. With the creation of Medicare in '65, we need to all remember that Medicare was not perfect by any means in '65. It got better over time. We need to also remember that Social Security, when it was created in 1935, left out many African Americans. They were not added to receive the Social Security benefit until 1952. So we got to remember, these kind of social programs got to take time, and they will be improved over time if we can sustain them. And I'm going to echo what Gordon said. We've got to make the ACA work. And this is your problem that you've got to deal with. How do we make the ACA work? And you advocate for what you need to advocate for. But we've got to make it work, or you're going to be losing too. So I think that we have to be careful what we're asking for. When TennCare was dissolved, it had a constituency of 300,000 people. So my question to you all, how big does our constituency have to be for the ACA in order for it to sustain itself and to basically move forward so it can be approved? Thank you.
I'm Mary Bufflack. I'm CEO for a community health center here in Nashville. And I've been asked to talk about some things kind of on the ground. And I know each of your communities is very different in terms of the configuration of what the system is, but hopefully I can point out some generalities that you can pay attention to in your own environment to understand some of the dynamics that are taking place locally. Because state by state, city by city, lots of local dynamics within the healthcare system are going to determine a lot of outcomes. First, let me say that, I was asked to talk about safety net, and some of your communities might be very different, but it would be very hard to characterize it in Nashville as a real net. And I want to talk about some of that fragmentation, because just as the entire healthcare system is very fragmented, duplicative, wasteful, the safety net might not be as wasteful, but it certainly is very fragmented. I think sometimes that's kind of the dirty secret, because we like to think that those who are caring for the underserved and uninsured maybe have their act together a little bit better in terms of how to make this all work. And in reality, if you are a community member, if you are one of the great folks that are uninsured or underserved, the system is just going to look very fragmented to you. You're going to go to your doctor's going to send you to a specialist, the specialist sometimes has your records, sometimes doesn't. The specialist sees you, never gets your records back to your primary care physician. The primary care physician never gets the records from the ER about what's happening to you. They don't get the discharge summaries, and yet that's where you go back to, and somehow out of that morass we're supposed to manage health care for these folks. So it's a very fragmented system in that sense that we don't share electronic health records, we don't share information well. It really means that we have a very hard time getting the maximum out of it and getting the real outcomes that we really want. So there's a persisting level of severity of illness among our underserved and uninsured, even if they do have at this point access to care, to the primary care that we provide. The other part about this is there's usually in a community no common registration process for being part of that care delivery system. Oftentimes we charge different amounts. I might have a $20 copay, someone else might have a $30. At the hospital it might be $60. So again, no similar set of rules about really how you're being handled in that healthcare system. So there's a great deal of coordination that's needed. Our community health centers, as most of you know, were created in the same years that Medicaid and Medicare were. We were supposed to eventually go away because universal health care was going to come, and we were no longer going to be needed. So we were just seen as a kind of stopgap to begin to see the underserved and uninsured that weren't covered by Medicaid and Medicare, and then eventually there would be universal health care. It never came. So now we have the Affordable Care Act. Hard to call it universal health care, isn't it? So really, part of the Affordable Health Care Act actually builds up community health centers. So the Affordable Care Act actually, rather than seeing this going away, sees this as a very important part, both in transitioning our underserved and uninsured to insurance status, and then continuing to be a medical home for those folks who really, as they come into the system, may not have very good access to primary care. So your community health center in your community is supposed to still have a very important role out there in terms of delivering the primary care. But when I look at, now, as you heard, Tennessee, or you know Tennessee, is not going to expand our Medicaid, at least not right away. And so really what we have is the insurance exchange, federally run, that we're trying to get people into. My estimates in terms of the about 16,000 uninsured that I see are that I'll probably in this first year be able at most to get about 10% actually enrolled. And so there's some real realities that we should really deal with in terms of how rapidly people who qualify get enrolled, all those people who don't qualify, that is all my homeless, my 40,000 homeless, who don't make enough money to actually fit into this system, the undocumented workers, those unauthorized to be in this country who still remain in need of health care. And then the estimates are in the first year for those eligible, you never can enroll any more than a third at the most anyway. Kaiser's put out the study that shows that they feel that in states where there is an expanded Medicaid, as much as 60% of the individuals that are uninsured will not qualify for that insurance exchange. So we've got a really big problem on our hands in terms of the inequality of the distribution of resources for those states particularly that don't expand Medicaid. I will say the other thing to watch out for in your community is don't confuse the ACA with the ACO, and I'm sure you won't. But it's very important to see how ACOs are developing in your community and what they're bringing to the table. In many communities, the ACO is usually being initiated by a hospital system. That's generally true because it takes a lot of capital, and hospital systems have deep pockets. So you see these mergers and acquisitions going on. In our own community, the ACO is actually buying up primary care practices. And so the way they're creating it is by now all the physicians work for the ACO, but the ACO is really being run centrally from the hospital. In some communities, it's more the insurance company that's running the ACO. But oftentimes it's really the hospital systems. Obviously the point is to develop cost savings, but I think we all know about hospital systems. They're not the cheapest alternative. If your community is like my community, it already has too many beds, and they have to fill them all in order to be economically viable. And so you add on primary care systems, you add all these other systems to essentially feed the monster. So this is not about health care. This is about the life of this monster. That we have 3 monster health systems in Nashville, and I will tell you it's a fairly cutthroat business. So who remains still dealing with the underserved and uninsured are going to be your primary care, your community health centers. Very necessary as we go into this system. And without the Medicaid expansion, this really isn't going to work. I mean, it's just, it really can't work because these mergers and acquisitions keep going on. And I know, should I choose? Well, should I choose? In some cases, I may not have a choice. For instance, one of the health insurance companies that's on our health exchange, it's a Blue Cross Blue Shield product. It's supposed to be very reasonable. But if you look at it, it has an exclusive network with only the Accountable Care Organization. So if I'm not a part of the Accountable Care Organization and that person comes to me, I can't see them. I have to send them off to, even though they might live across the street from my health center, this is kind of my duty to serve my community. In fact, the insurance companies are starting to do these exclusive agreements, and they're going to shut out certain people like myself from actually even being able to be part of the network. So in the end, what will I have? In the end, you know, there are people, this ACO particularly, who wants the TennCare, who wants the Medicaid, but they can leave those uninsured behind for me to take care of. And that will be my job again. Instead of being this diverse primary care center, I'm going to be reduced again to serving the underserved and the uninsured. So very important in your communities you support the efforts of your community health centers, because all of them are going to face these really difficult choices. And there are, in many cases, unless you have a very progressive community, not a lot of good choices out there. So again, very important that Medicaid expand wherever you are, certainly, but I do see that we are just going to have a lot of bumps and a lot of uninsured people left to take care of, and we don't want to see them left behind. Thank you.
Thank you very much to all our speakers. I think there's a lot of food for thought here, and I have a million things running through my mind. One that comes to mind is I was at a conference in D.C. some years ago now, like maybe 4 or 5 years ago, and these men from the Brookings Institution were talking, and one was from the Brookings Institution, one was from the American Enterprise Institute. And they joined together and said, this is what it's going to be. It's going to be Medicaid expanded nationally. It's not going to be Medicare. And sort of like, it's fixed. It's going to be that way. So I figured out, I'm going to ask this guy from the Brookings Institution afterwards, what's the matter with Medicare? And he just said, it's not going to happen. It would be better, but it's not going to happen. So I took very much to heart when Gordon and I'm sorry, Tony were speaking, because these guys fought hard for universal health care here in Tennessee. They got it and they saw it taken away. So I think they're speaking from hard-earned experience. And I want to kind of get into this question of the Medicaid expansion. We all see many holes in that, many problems in what we're going to get with the Affordable Care Act, even in those states where the Medicaid expansion is going to be fully engaged. However, it seems like we may be too great a distance from the goal of the present conference for a single payer. That's what I'm hearing a lot of. And I wanted to ask the speakers to talk a little bit about the tension between those two models, Medicaid expanded to cover people who otherwise are uninsured or underinsured or uninsured, versus real, true, single payer Medicare for all. Anybody?
Start. We're talking about healthcare justice tonight, and I think you need to look at the numbers of what all this is about. We have 925,000 people in Tennessee who are uninsured.
How many?
925,000 that would be eligible for insurance. Now, depends on what you get, though. If you're making 0 to 100% of the poverty level, you're not going to be covered by anything, because the Supreme Court said the states don't have to expand the Medicaid system. If you have 100 to 400% of the poverty level, you can shop the marketplace. That'll cover about 475,000 people. If you're over 400,000, the poverty level, you still shop the marketplace, and they'll cover another 50,000 people. Now, the hooker is that in addition to the people that make less than 100% of the poverty level and can't get anything, you also have a group of people in the Tennessee plan that the government wants to do. And I think he said something like 120,000 or 126,000 people hope to. 175. 175. Well, that group, that's just 175 of the 400,000 that's not going to be covered. Now, we also have another category, undocumented immigrants. In Tennessee, that's 128 to 140,000 people. Now, here's the thing that bothers me, is that this is not just immoral health care reform. This is health insurance reform. That's all it is. It's not a true health care reform. It's not just, it's not equitable, And we still are going to have big problems in our state with the lack of coverage for a large number of our population. So I'll throw it open for question.
Howard Newman, who was the first administrator of Medicaid at the national level back in the 60s, said famously, a program for the poor is always going to be a poor program. And that's been my experience with Medicaid, dealing with Medicaid for 35 years. It's not that it's inherently poor, it's that the people it cares for don't have political clout. TennCare could not have happened if the people who are the constituency of Medicare had been the constituency of TennCare. It would not have been dismantled. So I think, is Medicaid expansion ideal? No. I mean, first it's tragic that we're not doing it here and we're not doing it in 29 other states, and it's just a measure of how truly the inmates are running the asylum. I mean, in Tennessee, it's 100% money, federal money for the first 3 years. Is it